So, good evening, everyone. My name is Garima Bhatia, and I've been associated with Translumina. So, before going ahead with our DEBTalks, that is basically DCB, we would be discussing about DCB insights into emerging technologies into this modern era. I would like to thank you all for joining the DEBTalks, as we have named this. And just before going ahead with our, enriching basically the session, I would just like to take a few minutes of yours to share what Translumina is all about. So Translumina basically, known as limitless possibilities, wherein accompanies solutions with coronary interventions and was incorporated in the year 2000. So Translumina has its presence in more than 50 plus countries and has been certified with a great place to work with. And if we talk about the manufacturing units, we do have 5 global manufacturing facilities with 3 indigenous facilities over here. And R&D excellence is based at German Heart Center. So Translumina has been associated with 8 strategic partnerships with 10 years of clinical safety and efficacy with our stents portfolio and CE certified products with over 1 million implants. So our manufacturing facility is basically backward integrated test manufacturing facility in Germany and hosted regulators training program and study tool for high-end medical devices over there. And one is there in Dehradun as well. So this is our Asia's largest laser cutting facility situated in Dehradun, Uttarakhand. So world's first company to create 2 days technologies with 10 years of safety and efficacy data, that is Yukon Choice and EvoSR. And recently, just 2 years back, Translumina has further strengthened its technology portfolio with acquisition with Blue Medical Devices that is based at Netherlands. And the acquisition gives access to a patented, innovative, and proven next generation drug-coated balloons. That is Protege. Protege has been available globally, wherein R&D and manufacturing facility is based at Netherlands. And Protege is EU MDR certified with patented drug application process. So talking about the unique technologies of Protege, which is basically unique drug coding application process, which ensures the minimal drug loss during transition prior to inflation, and patented wing seal technology, which has corrugation over the surface of the balloon and ensures effective drug delivery at the lesion site without the drug loss. And just because the drug is secured so nicely and so tightly, possibility with same device is possible basically within the same vessel up to 3 times. So multiple inflation 3 times within the same device. And Protege is world's first only non-compliant drug-coated balloon that Translumina has basically launched. So coming on to our DEBTalks for the evening. So I would like to thank you everyone over here to taking your time out and sharing the insights over our the topics of the evening. So I would like to know if Dr. Abhisheka has joined.
Yes, sir has joined. Sir has joined. Sir has joined.
Okay. So I would like to invite Dr. Abhisheka Tripathi, sir, Senior Interventional Cardiologist at Zydus Hospital in Ahmedabad. So thank you so much, sir, and just handing over to you, sir.
Thank you, and I am extremely sorry that because of technical glitch, there was some delay from my end. But thank you, Ehsan, thank you for carrying it forward. And thank you, Translumina, for giving us this opportunity to discuss about something which was there since long, but now coming up in a big way. So I am Dr. Abhishek. I am from Ahmedabad. And today we are going to discuss regarding the drug-eluting, drug-coated balloons. This is there since almost more than a decade. But now since last, almost we can say for last 4-5 years, we have seen the use is increasing. And we are finding more and more challenging areas where it can be used conveniently with long-lasting results, particularly for bifurcation, for branches, small vessels, in-stent restenosis, for all these things. It becomes pretty handy. And if the patient is going for surgery early, elderly patients where the drug DAPT, long-term DAPT is going to be a challenge, this becomes pretty handy. So this is where the drug-eluting balloon started. But now we are seeing even in the good size native vessels also, where all these challenges are not there. We are feeling why to put a metal. So today we are going to discuss some cases, and we'll discuss our thoughts. What is the thought in general in the cardiology community regarding the drug-coated balloon? So today we have our speakers, Dr. Nirmal Kumar, who is Senior Interventional Cardiologist in Renova Century Hospital, Hyderabad. Our second speaker is Dr. Archit Dahiya, who is Senior Interventional Cardiologist at Holy Heart Hospital, Rohtak. Dr. Ankit Gupta, Associate Professor at AIIMS Raebareli. Dr. Arindam Pandey, Senior Consultant Cardiologist at Medica Hospital, Kolkata. And last but not the least, Dr. Parth Sarthi Sivakoti, Consultant Cardiologist at KIMS Sunshine Hospital, Hyderabad. So I think we will start the case presentation and discussion. I'll welcome Dr. Nirmal Kumar, Senior Interventional Cardiologist from Hyderabad, to present his case.
Thank you, Dr. Abhishek, for your very insightful initiation of the topic. Today, I'm going to discuss about the drug-coated balloons, and we'll start with the... My slides are visible?
Yes, sir.
Yeah.
You have to put in the slideshow, sir. It is visible.
Yeah.
Yes, sir. Yeah.
So this is the emerging technology of the drug-eluting balloon. And if you see the evolution of this intervention cardiology, 1977, first time the angioplasty, plain balloon angioplasty was done by Dr. Andreas. And subsequently, the problem with the plain balloon angioplasty is the elastic recoil, dissection, no flow, and emergency surgery. So that's at that time to overcome this problem. Then the bare metal stents came in 1988, and it addressed a lot of issue with the plain balloon angioplasty, and it's a good provides a good scaffolding, and they can go with the aggressive pre-dilatation and preparation. But the problem is that the intimal proliferation, high rate of restenosis. To reduce the proliferation, 2002-2003, again the anti-proliferative drug is coated with the stent is coated with the anti-proliferative drugs, and that reduces a lot of restenosis rate. But again, even with the new generation drug-eluting stents, there is still a polymer is a problem with the change of the polymer, thin stent, but still the late stent thrombosis and restenosis rate maybe it's reduced from 10 to 3%, but it still is there. So next generation is now the drug-coated balloon. So why the drug-coated balloon is a successful now? Why it was not successful in 1977? Because with the drug-coated balloon, now we have a full confidence that if we have any problem, any crisis, we have a strong support of stents, good stents. So now you can prepare the lesion we can prepare the lesion, and very well prepared the lesion with the semi-compliant balloon, specialized balloon. Even you can do the rota lithotripsy, so you have a good backup support. So now that's why the drug-coated balloon is become more popular. People are more confident, and if we find that there is a very good results and it fit into the criteria of a drug-eluting balloon, so no need to put a metal inside the artery. So that's why then is now pick up. This concept is picked up now. So if you see the restenosis casket, uh, anytime you inflate the balloon or stent deployment, it crushes the plaque, stress the artery, deendothelialization, lead to the signaling cascade, inflammatory response, platelet and fibrin get deposited at the injured site, lead to the smooth muscle cell activation, migration, vascular smooth muscle, cellular division that cause the new intimal proliferation and lead to the restenosis of the stent. So when you provide the anti-proliferative agent, it reduces the inflammatory response, it arrests the mitosis and emit the vascular smooth cell migration. That's why it's reducing the rate of restenosis. So what is the drug-coated balloon? It is a plain semi-compliant angioplasty balloon coated with a specialized drug and the polymer, and it delivers the anti-proliferative drug to the vessel wall when it gets contact with the vessel wall, and leave nothing behind the vessel. Any ideal drug-coated balloon should have anti-proliferative drugs. Most common, the large evidence is the paclitaxel. Sirolimus is also gaining a data, and it should be lost to the circulation. While like a protease, they have already, Garima has described, is a threefold balloon. And during the transition, very limited loss of the drug during the transition, and should be a transfer efficiency should be good. The paclitaxel is always better. There is a rapid transfer of the drug. Same time, there are two type of a coating, crystalline coating and amorphous coating. They have advantage and disadvantage, but most of the time it's a crystalline coating, because amorphous coating they have found the more distal embolization. Plus excipient. Excipient is a carrier. It is a carrier which deliver the drug from the balloon to the vessel wall. And most likely they are using a ATBC. Most of the time ATBC or STBC type of excipients they are using. And dose, every drug has its own dose, but usually is 2 to 4 microgram per millimeter square. So paclitaxel is the most favored drug for short-term exposure, high absorption into the vessel wall in contrast to the limus. Is a half-life is only 6 to 13 hours, highly lipophilicity, so it resides in the tissue for a prolonged period. But at the same time, and the effect on the vessel wall no longer noticeable after 10 to 14 days. And in demonstrate the luminal environment and a positive vessel, the advantage of the paclitaxel over a sirolimus is the late luminal gain. The late luminal gain is with all the drug-coated balloon, but paclitaxel shows a better luminal gain in comparison to sirolimus. And this quick vessel healing and faster endothelialization, as Dr. Abhishek told, reduce the DAP therapy. The duration of the DAP therapy it can be decreased. So if you compare the paclitaxel versus sirolimus, paclitaxel is a cytotoxic drug, sirolimus is a cytostatic drug. And sirolimus has a good anti-proliferative effect and anti-inflammatory effect also. But being the paclitaxel is a cytotoxic drug, is a good anti-proliferative drug. But as far as the safety margin is concerned, the sirolimus has a 100% more safety margin than the paclitaxel. And retention is also, and long-term stability is also good with the sirolimus. So that's why the research is also going on in favor of a sirolimus. But still at present, we have a large evidence with the paclitaxel balloon only. There are so many studies have been done, everybody knows, and the basket is small to restore SVD. The recent trial has shown a better result than the stents. And what is the criteria for DCB development? You should achieve the optimal lesion preparation. If it is simple, soft lesion, you can use the semi-compliant or NC balloon. If it is a fibrotic calcified lesion, you can use a specialized balloon like a scoring balloon and cutting balloon, 1:1 balloon to vessel ratio. And you can use the specialized these things like a rotablation and lithotripsy. And the same time, you can use the FFR to see that is a hemodynamically acceptable or not. If the FFR is more than 0.8, means it is a hemodynamically acceptable for the drug-eluting balloon. And if you find that any suboptimal result or anything, you can do the imaging also. For imaging, you can see the size of the should be the size of the balloon, length of the balloon, and how much better you have done the lesion preparation. You can use the IVUS and OCT, but post balloon usually the people use more with the IVUS rather than an OCT. There's another merits and demerits are there. And the optimal angiography criteria is there should be no flow limiting dissection, and the residual stenosis is less than 30%, and FFR should be more than 0.8. If the criteria are met, you take the balloon, go inside and inflate. It should be a short delivery time. If you are using a very long balloon, very tortuous vessel, you can do the test run also. You can take the normal stent balloon and go and see the balloon is crossing the lesion easily or not. Sometimes, because if you are keeping the balloon, a drug-coated balloon, long time in the artery, or you are trying to negotiate, all the drug will be washed out. And there should be a sufficient inflation time, 30 to 60 seconds. If it is a de novo lesion, 30 seconds is also sufficient. But if the patient has an instant stenosis, better to keep the drug-eluting balloon for 60 seconds. If there is no criteria met, you should use the drug-eluting stents. So what are the indication of the DCB? You know, the in-stent stenosis is a very well acceptable indication. Now it is a class 1 indication for DCB in-stent stenosis. And now we are gaining the momentum for small vessel, de novo lesion, and bifurcation lesion also. If you see the ISR, the concept is that you are putting a metal inside the metal. Again, the risk of restenosis is more because of inflammation, because of a polymer. There is inflammation, so it is a chances of restenosis is more. Suppose that you put the drug, if you applying the giving the strategy DEB strategy, it release the anti-proliferative drug into the vascular walls, inhibit the anti-malarial, reducing the rate of in-stent stenosis, and there is a no inflammatory response. So this is the case I have done in our center. This is our center experience. You can see this is the pre, this is the post, this is the lesion, and we have done, because it's a calcified lesion, we have done the rotablation. After rotablation, we have done the drug this is cutting balloon, and after cutting balloon, we have done the paclitaxel drug-coated balloon. And you see the result. The result is very good, and we live because there is a no residual lesion, no flow-limiting dissection, and this is the result. Another is the small vessel disease. A small vessel disease already we know with the basket small 2 trial, because in the small vessel, if you put the stents, there's a risk of stenosis rate is higher, and late luminal, and another challenge is the late luminous and higher stenosis rate. So you see this patient, this is the young patient, diabetic patient. You see the vessel. Whole LCX and OM is a totally diffusely disease. What you will do, where you will put the stand, where is the landing zone? So what we have done, we have used the cutting balloon and then put the drug-coated balloon, and you see the result. Because with this kind of a lesion, if you use the drug-coated balloon, there is a late luminal gain of the artery. Later on, if you do the angiogram, you'll find the normal artery, healthy artery. Or if they get a lumen gauge, you have a good lumen space to put the stents also in the future. Then this is the bifurcation. Again, bifurcation, either you put the stent in the main vessel and go with the drug-coated balloon in the side branch, and has shown a better result, better outcome. And 2 trials is called DCB trial and hyper study. Both the trial have shown a better TLR and less restenosis rate as comparison to the 2 stents. This is the LCX-OM bifurcation lesion. You see the 2 lesions are there, very well prepared with the drug coated with the cutting balloon. What I will say, any patient is, if you are using a DEB, better you use the cutting balloon or scoring balloon before using the drug coated balloon, because it will produce the micro incision or microcalcific fractures, and you will get the good expansion, good luminal gain. So DEB is always a better of drug. This cutting balloon is always a better option before the DB. This is the well prepared. Then we have done the kissing balloon, and then we have put the drug coated balloon. One thing again I want to say: the drug coated balloon is not a dilatation not for dilatation. It is not for dilatation. This is the balloon is only for delivering the drug. This is misnomer is a balloon. It's not a balloon. Only thing you use the drug-coated balloon to deliver the drug at the lesion site. But don't expect there's a dilatation and another thing with this balloon. So prepare the lesion very well and take the balloon, deliver the drug and come back. Another is the de novo lesion. There's a lot of trials in the favor of DCB, and these are extensively studied, and recent trials are going on. This is the de novo lesion. Is a 32-year doctor patient developed the non-ST elevation MI, and this was the lesion. So what we have done, we have used the cutting balloon And then we have used the cutting balloon, used the OCT, and say there's any plaque erosion was there, and then we put the drug-coated balloon, paclitaxel-coated balloon, and you see the result. Vessel is very healthy, good one, no rheology is normal, washer motion is normal. So these are the advantage, young patient without any metal inside, and you cannot, and no need to use a DAPT for a very long time. Diabetes mellitus, high bleeding HBR patient, we know the diabetes, we have a challenge with the diffuse coronary disease, small vessel disease, tortuous vessel anatomy, and sometimes difficult stent delivery because of tortuous anatomy, diffuse disease, no place for a
You are not audible, Nirmal.
You are on mute, sir. Sir, Nirmal, sir, you have become muted, sir.
Yeah, my slides has gone.
Oh,
Sir,
yeah,
please
yeah.
reshare.
Please
I
do
do
reshare.
more.
You have to share it again, sir. It has come, sir. It has come now.
Now you can see my slides.
Yes, sir.
It is visible now.
Okay. I will not take much time because this is given only 10 minutes to me. This is a one CTO lesion, not correct, say not true CTO, but it is a large diagonal branch presented with a non-ST elevation MI. And we have opened up the artery and then done the drug-coated balloon. And you see the result is very good. Even in the CTO, now the concept is there. You can use the drug-coated balloon in a CTO because once the antigrade flow you establish, they cause the positive remodeling of the vessel. So after some time, if you see the vessel vessel grows, and you can put the stent. Second thing, CTO bifurcation lesion also. You can put the stent in the main vessel and lead the bifurcation with a drug-coated balloon. The CTO also, we are gaining momentum of the drug-coated balloon. If you see the SWOT analysis, the strength of the drug-coated balloon is preserve the vessel anatomy, reduces the long-term complication, shorter DAPT duration, and maintain the future treatment option for a complex coronary intervention. The weakness, higher initial revascularization rate in some studies. We have a limited long-term data availability, requirement for optimal lesion preparation, and drug delivery variability concerns. The opportunity is growing clinical evidence supporting expanded indication, emerging dual drug formulations, improve the drug carriers, and increase adoption in the complex lesion subset. Now, what is the threat is? Now the drug-eluting stents also, there is advanced drug, there is a competition with the advanced drug-eluting stents, regulatory approval challenges, cost consideration, and limited reimbursement coverage in the certain healthcare system. What is the next generation drug-coated balloon innovation? Now the dual drug formulation is there. Just I told you, the sirolimus is a more safety margin is more stable molecule. So now they are this thing, the new generation or this thing, the combination of the sirolimus and paclitaxel for enhanced therapeutic outcome and improve efficacy. Novel drug carrier, there research is going on for a novel drug carriers. Now the everolimus drug-coated balloons research trials are going on because we found the everolimus is the best limus in the drug-eluting stents. Then biodegradable coating, that will it is more, there will be less inflation. Then target delivery therapy, precision medicine approaches with lesion-specific drug. Like if the patient lesion is a very soft, you can use the sirolimus. Hypoxia bifurcation, sirolimus has shown better. But if the instant stenosis, paclitaxel is better because it's a very good strong anti-proliferative activity and a cytotoxic drug. And clinical development pipeline is a major trials are going on, and like a solution de novo trials, transform 2 trials on the de novo lesion, magical trial, And the main focus is the long-term clinical outcome and safety profile, optimal patient selection criteria and lesion characteristic identification, and cost-effective analysis. They are also integrating with the AI, with the artificial intelligence guided procedure planning and optimization, and patient-specific drug selection and dosing protocol development, and hybrid approaches combining the DCB with the adjunctive therapies. So take-home message is, for clinical presentation, any patient who is a high bleeding risk patient, HBR patient, older patient, small vessel disease, or patient has a instant stenosis, DCB only strategy. Younger patient, acute coronary syndrome, bifurcation, multivessel disease, you can use the hybrid. Like a multivessel, some places you can use the, rather than putting a multi-stent, you can use the, if there is a distal diffuse disease, you can use the drug-coated balloon, and proximal 3.54 millimeter vessel, you can use the drug-eluting stents, because in the younger patient, proximal LED, you cannot take risk. If the patient has a high ischemic risk, don't take a risk. Go ahead with the DES. And if the large vessel trials are going on, but still drug-eluting balloon is a question mark, and calcified complicated acute coronary syndrome, the drug-eluting stent is a better approach. Thank you.
Thank you, Dr. Nirmal, for taking us through the entire journey of balloon angioplasty evolving to the DES and then following now the drug-eluting balloon. You have covered almost all different kind of cases with wonderful results. So this was a great learning point for all of us. So I just want to understand from Garima, shall we take question answer now, or shall we keep it in the last, Garima?
Sir, as you say, sir, we can have sessions first, maybe?
Yeah, I think in the interest of time, we'll finish this week sessions first. So,
Dr. Abhishek, sir?
yeah.
Yeah, we have Dr. Archit Dhaya, sir, to present.
Yeah, Dr. Archit Daya, Senior Interventional Cardiologist from Holy Heart Hospital, Rohtak. So, Dr. Archit, please start your talk.
Thank you, sir.
Thank you so much.
I will share my slides. Nirmal sir has very wonderfully explained the drug-coating balloons and the indications. I'll keep my presentation short and discuss the few trials regarding these indications. So, drug-coating balloon beyond instant release stenosis indication. These are developed to deliver anti-proliferative drugs to the vessel wall without leaving any permanent prosthesis or durable polymers. The purpose is to reduce the risk of very late stent failure, treat more lesions with less stent, reduce the need for long-term DAPT, reducing associated bleeding complication. The clinical practice guidelines recommend DCB for the management of instant restenosis only. There is an increasing number of positive data on the treatment of de novo stenosis, particularly in small coronary vessels and risk indications. So this is the gist of this presentation, and these are the potential benefits, and these are the main indications for which we use drug-coating balloons. These are in stent restenosis, in small de novo small in de novo small coronary artery disease, in de novo large coronary artery disease, in bifurcation lesions, in diffuse coronary artery disease, in patients with diabetes, high bleeding risk patients, and acute coronary syndromes. We'll discuss few trials for these specific indications. First, for the de novo small coronary vessel, the first trial is the Restore SVD in 2020, published in 2022 with a 5-year follow-up, and it showed that there was optimistic results reported regarding all-cause death, MI, and any revascularization, and no device thrombosis. The second trial, this was published in 2022. There was similar rates of MACE and all-cause death, major bleeding, and probable definitive stent thrombosis were numerically lower in the drug-coating balloon group. In the Picoletto 2 trial, at 1-year clinical follow-up, MACE rate occurred in 7.5% of the DES group and 5.6% of the drug-coated balloon group with p-value of non-significant. And after 3 years, a significant reduction in abrupt vessel closure and MACE was observed in the DCB group. Another is a meta-analysis of 5 RCTs. Drug-coated balloons are associated with lower late lumen loss compared with drug-eluting stents, as well as with a lower risk of myocardial infarction, similar risk of MACE, death, target lesion revascularization, and target vessel revascularization compared with death at 1 year. And another meta-analysis showed that the use of drug-coated balloon was found to be associated with a similar risk of target vessel revascularization and target lesion restenosis and all-cause death, with a significantly lower risk of vessel thrombosis. For the large coronary vessels, the one trial was this in 2022, in which the late lumen loss was little more in the DCB group versus the DES arm, while 12 months MACE was similar. And in another trial in 2022, reported that the drug-coated balloon use was safe and effective for both bifurcation and non-bifurcation lesion. And 2-year follow-up revealed and the target lesion failure, target lesion restenosis, and target vessel revascularization rates of 4, 3.4, and 4.2 respectively. This another trial of with a follow-up of 16 months showed that the target lesion revascularization rate in the de novo group was significantly lower than the ISR group, with no difference in terms of post-operative or follow-up mean lumen diameter. And the last one was the with a 12 months follow-up. The outcomes were similar between the two groups, suggesting the feasibility and safety of this stentless approach for osteal lesions of large vessels. Now coming to the use of drug-coated balloons in the bifurcation lesion, and the Corballis in 2021 in a meta-analysis reported that the drug-coated balloons were associated with lower late lumen loss with p-value significant. And the Zheng et al. Reported that the lower rates of MACE in drug-coated balloon groups. However, no difference were found when analyzing the individual components of MACE. Another trial showed that DCB therapy of the side branch was linked to late lumen gain in 71% of the cases. The authors also compared patients with late lumen gain and those with late lumen loss, showing numerically lower MACE and target lesion revascularization rates in the late lumen gain group. So the DCB is superior in gain for the late lumen gain as compared to the DES. And the last one is the hybrid strategy was superior to a two-stent strategy in terms of late lumen loss, both at the side branch ostium and at the proximal main branch. And for long and diffuse lesion, after 3 years of follow-up and no significant difference in target lesion revascularization and MACE rates were described. Of note, similar target lesion revascularization and MACE rate were observed between the drug-coated balloon only and hybrid strategies. The late lumen loss was considerably lower in the drug-coated balloon group than in the DES arm. Coming to the patients with diabetes, the Penn et al. With a 1-year follow-up reported in 2021 that there was a higher target lesion failure and similar rate of MACE in the diabetic group compared to non-diabetic patients. Another trial showed that higher rates of target lesion failure among diabetic patients, similar rates of myocardial infarction and MACE when compared to non-diabetic group. And another trial showed that drug-coated balloon was superior to DES regarding MACE, occurrence of MI, target lesion revascularization, target vessel revascularization, target lesion restenosis, binary restenosis, late lumen loss with respect to midterm outcomes. However, the long-term outcomes were similar. The Eastbourne subgroup analysis published in JACC 2023 showed that diabetic patients had similar target lesion restenosis and higher rates of all-cause death, MI, MACE, as compared to non-diabetic patients. In high bleeding risk patients, it was associated with higher mortality rates at 3 years, while there were no difference in terms of MACE between DCB and DES in overall populations. DCB showed similar rates of major bleeding in high bleeding risk patients and lower rates in non-high bleeding risk patients. The use of DCB in acute coronary syndromes, a meta-analysis involving STEMI and STEMI patients, there were no difference between the group regarding the incidence of MACE or its individual components. The drug-coated balloon group was also with lower late lumen loss. Another trial showed that patients presenting with an ACS, out of which 50% were STEMI, there were lower rates of cardiac death and MI in the DCB group. And to conclude these various trials on the DCB in comparison to POBA and drug-eluting stents, the potential of DCBs are tackling limitations of current era DES. Drug-coated balloons have the potential to address limitations of DES in various clinical and technical settings. New angiographic and clinical scenarios like effective in large de novo coronary lesions, suitable for bifurcation lesions, useful in diffuse CAD, applicable in acute coronary syndrome, beneficial for high bleeding risk. And the last 2 years have seen significant developments in drug-coated balloon technology and clinical data. And for the future validation, ongoing larger clinical trials with long-term follow-up are needed to validate the efficacy and safety of drug-coated balloons in these settings. Thank you. Although I have not made a case presentation, but we did two cases with drug-eluting balloon recently. One was a posterior wall MI with a distal LCX, small vessel, and a large OM, 90% lesion. We did the drug-coated balloon in the distal small vessel LCX and did PCI with DES in the OM. And the second one was the ostial LCX, 90% lesion. And the LAD ostia and the left wing were not a significant lesion. So we just did a drug-coated balloon at the ostial LCX with a good lumen gain and with a good end result. Thank you.
Thank you, Dr. Archit, for taking us through the evidence what we have for drug-coated balloon. Regarding your cases, this ostium circumflex, even through post LMCA to LAD stent also, and particularly for the native and de novo osteal stenosis of circumflex, the drug-coated balloon becomes very handy, very useful because it avoids metal at the very junction of the left main and LAD. So that is a very unique, and I believe that this is almost a best use of a drug-coated balloon, which is there. So wonderful. I think we'll move on to the next talk, Dr. Ankit from AIMS Raebareli. Dr. Ankit, we'll keep the discussion session for the last. Dr. Ankit Gupta. We have Dr. Ankit with us?
Yes, sir, we do have, sir.
Dr. Ankit is mute. I think he's mute.
Yes, sorry for the delay. Let me share my.
Yeah.
Can anyone see my?
Not yet. Not yet.
Not yet. Okay. No.
Yet to see.
Oh, shit.
So shall I help you in this?
Yeah, please.
So there is a basically icon of share, a green icon of share on the screen. So you need to click on that option basically, and then your screen for the presentation, you need to double click, and that will be there on the screen then to us. A green color share option is there on the screen.
There's an option, but they are asking for the security. I don't know why, but open the setting system. I don't know.
Have you kept your slides open, sir?
Yes.
So just you have to share and then select. It should not have. Sir, in the meantime, we can also do is that, sir, you can send the slides to us and we can run from our side on your behalf. If in the meantime, the other speaker can speak, in the meantime, we'll organize it for you, sir.
We can. Oh, I don't know why.
Is it now? Just have a try, sir. Because I have not kept anything to share via passcodes. So that is all open for all the faculties.
No, but there was some issue with me also. Like I was not unable to open when you shared the latest link only then I could open. So I can understand Dr. Ankit's condition, which was
Yeah,
I don't know why it is happening. Lock screen. I don't know.
Sir, I would rather suggest it would be better, sir, if you can share the slides to me or Garima. I'm writing the email ID. I'm just writing it for you, sir, for your benefit. In the meantime, we can have Dr. Arindam or
Hi, it will be more better if it is
uh,
possible,
mhm.
because I don't know, but it is already open, but it is not showing.
No,
It
no,
is
no
not a
worries, no
problem,
worries.
sir. We can
no
share
problem.
it from your behalf. Not a problem, sir.
Dr. Ankit,
Yeah.
you, I think Garima,
Garima, you can do the
Okay.
needful. That.
you
Yeah,
help Dr. Ankit
And
in the back end.
yeah.
In the
yeah, sure.
meanwhile, we'll request Dr. Arindam Pandey from Kolkata to go ahead with his talk. And in the meanwhile, prepare Dr. Ankit's presentation, please. Dr. Arindam.
Thank you very much.
Thank you.
So, okay, my screen, is it visible?
Not yet.
Not yet, sir. Just coming, sir. Yeah, it's now.
Yeah,
Yes.
now it is visible. Yeah.
Now it is visible.
Yeah.
Okay. So, paclitaxel is it the DOC, that means drug of choice, in DCB, that means drug-coated balloon. So, my job has been made easier by my previous speakers. They have delivered very nicely the rationale of using drug-coated balloon in situations, as well as whatever data we are having in favor of paclitaxel and sirolimus. We are discussing that throughout this evening. So the principle of DCB actually is to leave nothing behind. Now we do have option of paclitaxel and sirolimus. Paclitaxel, as we all know, as a drug-coated stent, this has some limitation, but those limitations are actually advantageous when we use it as drug-coated balloon. So it has irreversible blinding and it is lipophilic. So you can see the cytostatic action is achievable at a very lower dose of less than 100 nanogram per milligram. Whereas sirolimus is actually having a reversible binding, it is hydrophilic, so very difficult to deliver because it will wash away. And this paclitaxel molecule has very strong anti-proliferative action. It has moderate anti-inflammatory action. So as a result, we get something as a benefit. There is something known as moderate positive remodeling, which is not seen with sirolimus. So there is prolonged tissue retention and long-term stability in the site, crystalline form. So that was a disadvantage whenever we tried to use paclitaxel in our drug-coated stent. Now that has become actually an advantage for drug-coated balloon. So sirolimus, as I mentioned, is having less positive remodeling, shorter tissue half-life, and unstable outside the protective media. That is why my personal choice is always paclitaxel. I use most of my cases with paclitaxel drug-coated balloon. I do get benefit, but there are always positive and negative side of all the story. I'll show you a few cases. So here you can see this is a relatively young gentleman, very significant angina, almost unstable angina kind of feature, very non-dominant but large left circumflex is having critical stenosis. He was a smoker, very significant chest pain, TMT positive. So this is a LCX which is more than 3 millimeter. In fact, if we do a IVAS, it might be more than 3.5 millimeter as well. So always there is some confusion in this kind of big or large vessel, whether we should go ahead with only DCB strategy or not. But looking into the age of the patient, after detailed discussion, the positive and negative side, we decided to go ahead with the DCB strategy. So this is how we proceeded. We took a cutting balloon. This is a 3.5 millimeter cutting balloon. You can see. Sorry, this was a 3 millimeter 3x10 Wolverine cutting balloon. And after serial pre-dilatation, this was the result. Then we took a larger non-compliant balloon. This was a 3.5 millimeter non-compliant balloon after post-cutting balloon pre-dilatation. Then a protege was taken. This is the protege dilatation. You can see the protege is kept for quite a long. I try to keep the vessel inflated, because always during the pre-dilatation, during cutting balloon or non-compliant into balloon dilatation, I make a point to go for longer and longer duration inflation. And this protege was kept for around two minutes. And this was the final result. You can see, everybody will appreciate that without stent in such a young person, 42 years old, had significantly good result. This procedure was done around 6 months back. I have done 2 follow-up. As of now, patient do not have any kind of any symptom. Another case I'll show. This is basically by profession, ophthalmologist. He was actually a diabetic person. LAD mid-distal was a CTO. So we had discussion whether we should go ahead with opening the CTO or not, but he wanted to have, all his vessels opened. So even a mid-distal LAD, we opened the CTO, and actually he was having good amount of angina, though controlled with OMT. So we had quite a good discussion whether to keep on medical therapy only or intervention, but somehow he insisted to have all his open arteries. So LAD open, this deployed. Then we had option of doing DCB to OM1, OM2, and RPDA. So accordingly, we can see the in my practice, most of my cases of DCB, almost more than 95% of cases, I do a pre-dilatation with a cutting balloon. This is exactly the same thing is being done. You can see it is initially done in the LCX, followed by DCB treatment. This is the main LCX, then the OM1, again serial cutting balloon, followed by DCB treatment. And this was the result final on the left side. You can see the LCX CTO is open, and the both large OM1, OM2 is flowing without residual stenosis, significant residual stenosis, without very significant die hole. That means there is no hemodynamic significant dissection as well. So RCA, again, you can see the RPDA is a big vessel, quite large territory with a significant stenosis. So similarly, we did cutting initially the lesion was very tight, so 1.5 semi-compliant, followed by cutting balloon dilatation, then DCB. This is the DCB, and you can see the final result. So all these vessels, as per the wish of the ophthalmologist, was opened. So third case I'll show is basically a case of chronic total occlusion, CTO. You can see RCA distal CTO. So this was opened with a dia wire, followed by wire exchange, pre-dilatation, cutting balloon pre-dilatation, followed by DCB. You can see this is the DCB, again paclitaxel eluting DCB, and this is the final result of the RCA chronic total occlusion. Even chronic total occlusion nowadays we have started using DCB, not in all cases, but in selective cases. Particularly this particular patient, lady, had proximal moderate calcified lesion, so we thought better to not deploy a stent. So I have shown you multi-vessel, small vessel, large vessel. A CTO now is a turn for ISR. This is a lady, poor lady. We did angioplasty in January 2023. 2 synergy stent was deployed in the proximal part of the LAD, but somehow she had very significant restenosis. You can see the restenosis with very significant symptom. Now, we did IVUS. IVUS showed some calcification. So probably this was sort of neoatherosclerosis, but it happened within a span of 1 year only. So we thought what to do. Let us do some DCB treatment. So accordingly, cutting balloon followed by quantum apex 4.5 and OPNMC 3.5, 10 atmosphere at 40 pressure we went. And after doing all this pre-treatment, you can see the DCB is done. This was again a DCB 4 millimeter. We deployed in the distal vessel, distal part as well, and post DCB. This was the result. Very acceptable result. You can see the very nicely opened. But today only today, this patient, I did a check angio because she started having some sort of chest pain on exertion. So this is 2025. The initial procedure was done January 2023. We did the DCB treatment after 1 year in March 2024. And in this August 2025, you can see this is 2 days angio only. So again, the stent looks very much nicely deployed, but the patient landed up with stenosis again. So not all the time your strategy works. This time, this is the strategy. You can clearly see the stent is very nicely open, but there is significant ISR. So I thought I sent this patient for minimal invasive bypass surgery today. So not always your strategy works. So this is another case. RCA was intral MI, acute intral MI with window presentation. So we did angioplasty of the RCA. Then there was multiple blockage on the left side. It was staged, and you can see the vessel was small. So it was managed with DCB, the LCX, and as well as LAD. LAD again had a bifurcation distal stenosis. Again, this was managed with cutting balloon followed by calcified vessel, cutting balloon followed by DCB. I mean, paclitaxel eluding DCB. We checked the RCA because it was done 1.5 months after the primary PCI. So RCA stent was doing good. So last case, high bleeding risk, significant angina. So you can see the OM is having very critical stenosis, ostium. So we went ahead, did pre-dilatation with cutting balloon, followed by DCB. This was the good result, you can see. Final result of the OM, reasonably acceptable. LAD also we tried to do the same, but not always your strategy works. You can see we did pre-dilatation, but ultimately patient developed a spiral dissection with flow limitation. So we had to deploy a stent. So it was a big LAD, we could not take risk. You can see type 4 LAD. So I showed all kind of cases where my DCB was successful. In some of the cases, my DCB was not successful. So rest of it is to the discretion of the moderators and chairpersons.
So, very beautiful cases, Dr. Arindam. And I like the real presentation, the success, as well as where they were not very successful. And the basic point of discussion from my side would be a very liberal use of cutting balloon. Maybe that is the reason of success or what. So we'll touch up this point. If I forget, you please bring up this point of discussion regarding the cutting balloon, liberal use of cutting balloon. So in the interest of time, we'll move on to our next speaker. Is Dr. Ankit ready now?
Yes, sir. Sir is ready.
Yes, doctor. I can share your pain.
Ankit sir, shall
you
I
can
share the screen?
Yes, of course.
Okay, so just a second, please. So hope my screen is visible.
Yeah. Thank you. A very good evening to all, and I'm very thankful to the Transluminate. Everyone can listen me, no?
Yes. You are
Always
absolutely audible, and the slides are well visible.
Thank you for giving me the opportunity and the platform in front of all the legendary senior cardiologists. So here is the topic where how do I confidently expand my DCB practice? So next slide. Next. So there are a few points we have already discussed about the evidence-based indications. As we all know that the clinical guidelines are limited to the restenosis, instant restenosis, and few with the small vessel and the bifurcation disease. But now the emerging with the emerging technology of the calcium modification we can easily use in few other native vessels also. Next. So for practicing the DCB, we should the selecting the patient is the most important thing for the DCB therapy, particularly who are with multiple comorbidities like diabetes or the elderly, very diffuse diseases, and to reduce the stent uses is preferred, and moreover the delivery of the drug is depend on the preparation of the arterial bed, which is more important for acquiring the ensuring the optimal drug delivery, and the device option. So which type of drug is to be delivered at the injured or the lesion. Next. So we have some intravascular imaging modalities like IVUS and OCT, which can easily tell us about the lesion, whether it is a calcium or the fibrotic, which is more important. I'm going to present a case for the intravascular imaging that gives help in various cases in the cases with the young. MI or the coronary artery disease, or in the with multiple comorbidities. Next. So about the clinical experience, we have some. We need to do the different type of cases. Then only we can get that much of clinical experience. So this is in the emerging and the new technology that we need to practice. Then only we can know which type of lesion we can go for the DCB therapy. Next. So there are various clinical trials also we already have discussed in previous speakers. Now we have some trials, big meta-analysis with a transform or transform 1 or 2 by European cardiologists. So now we should also go through some DCP research, as we Indians are using it so much now. I think more than the European or American cardiologists. Next. Next. So here I'm going to present a just 29-year-old male who is actually a army person, who is a volleyball player. He came us with a exertion angina. So I thought there must be some there must be some non cardiac only. Then there was no findings in the ECG, and even during the TMT also, he was able to run around 3 to 4 minutes only. Then he had some angina. So that was the thought. I thought maybe some other reason. So I go with the CT coronary. So then we got some plaque. It was in the report that there is a plaque in the LAD, proximal LAD, that was 25 to 40%. Still, it was not clear exactly the what is the reason. There was no comorbidities, no family history, nothing was there. The trop I levels and everything was normal. So next, I thought I should go for the angiography, and where the angiography, we can easily see there is only mild plaque in the LAD, proximal LAD, and there is a huge big diagonal, to diagonal, where at just after the plaque, a mild plaque. Next. It is the only Next, only just one shot where the alveocaudal, where we can easily see that there is some diffuse plaque, maybe 60 to 70% at proximal, where the three vessels are just dividing. But it was still not clear. The RCO was perfectly fine. It was flowing with the good flow. So that reason I went for the intra coronary imaging, that is IVAS. Next. Next. Now we have done the IVAS where the it was not the much information I've got with the angiography. Then I went for the IVAS where we can easily see there is a fibrotic plaque, which high burden of the high burden fibrotic plaque, where the MLA was just 3.2 at the proximal LED. Now with this imaging, we went for the next. Next, what we have to do, we need to cut the fibrotic plaque. I took 3.25 10 cutting Wolverine balloon and cut it around 2-3 times with just some movement, so that we can easily cut at all the directions. So I thought to give it a good cut. Thereafter, I just put 3.525 DCB for around 1 minute 60 seconds. Next. Now the plaque is modified and the plaque burden is low with a good luminal area. Now that it is more than the 6. Next. And the angiography, which we can see in the alveocaudal also. Next, in the alveocaudal view, where we can see that there is a good luminal flow, a TME3 flow at the alveocaudal, the same view where we got some plaque burden. Next, and the patient is discharged with now he has no angina. The expanding the DCB practice confidently requires a combination of clinical knowledge, patient-centered care, and technical skills, and most important, ongoing professional development. Thank you.
Thank you, Dr. Ankit. This was a beautiful case and actually eye-opener. The classical example, if you see all the 3 branches, LED, septal, and diagonal, and combining their total diameter, it was pretty significant. So again, we will discuss this case as per our commitment once we have finished all the cases. So our last speaker of the day, last but not the least, Dr. Parth Sarthi from KIMS Sunshine, Hyderabad. So Dr. Parth.
Yes, thank you for the introduction.
Yeah, please share your slide.
Yes, okay. I think my slides are visible. Yes.
Yes.
Good evening, everyone. There is nothing much to say because already the previous speakers have covered everything, even the trials and also the trial evidence and also the indications of the DCB and the recent development in the DCB technologies that are being studied right now. So I'm going to present a few cases what we have done with DCB. So I'm going to what are the treatment options for the side branch? So DCP predominantly helps in preserving the vessel patency, and also it has got potential benefits like the reduced risk of stent thrombosis, reduced risk of progression, and also better angiographic and clinical outcomes. And also there is a reduced target lesion revascularization. So what is the evidence of DCB in side branches? So they have done a systematic review and meta-analysis in 2021 that has been published in Frontier of the Cardiovascular Medicine. And DCB has a great effect in side branch protection for coronary bifurcation lesions at short-term, medium-term follow-up with no reduction in the procedural success rate. So these are the studies that is indications of the DCB. And also the largest trial here is the basket small 2 trial, where the study population is around 750 patients. And also they have followed up the patients for 3 years. And it is a non-inferior trial compared to DES. And also there are similar rates of MACE and also all-cause mortality. And another trial, that is Piccolato 2 trial, that has been studied in China, that has been a follow-up, angiographic and clinical follow-up at 1 and 3 years, where they have compared DCB versus everolimus eluting stent. At 1 year, there are similar MACE rates, and also there is a reduced risk of abrupt vessel closure, and also the thrombosis, no evidence of thrombosis in the DCB arm. And also this Megali et al. There's a meta-analysis that showed the lower late lumen loss in DCB group compared to the DS group. So this is the DCB in SVD, that restore SVD. Here you can see there are no much difference between the DCB and the DES, and also the p-value is not that much significant. But however, there are similar results compared to the DES when comparing with the DCB. And this is the MACE events chart showing the comparison between the DCB and the DES. Here you can see the vessel thrombosis is seen in the DES group, and also the MACE events are more in that DES group, that is 20.8% compared to the DCB is 10.8%, and it is statistically significant. And this is one more trial. The sample size is less, but however, here you can see they have done the plain balloon angioplastic and also the DCB comparison. Here you can see the side branch restenosis rate is lower in the DCB group, TLR and also MACE events are lower in the DCB group. But however, these are not statistically significant because the sample size is small, and also there is more studies are also needed in the future, and also the larger sample population will helps to show the superiority or maybe the non-inferiority of the DCB compared to the DES. So I'm going to present few cases where we have done the DCB. So this is a 81-year-old male, diabetic hypertension, presented with ACS. Presently he was in failure at the time of angio also. This is the angiogram. Here you can see there is a densely calcified LAD, and also there is a tight stenosis in the LCX, and also tight stenosis in the proximal RC. And here the LAD is the culprit, so that's why we just want to address this LAD. And distal LAD is also diffuse disease, and considering his age and also the diffuse disease nature, CAB is not an option in this case. So we proceeded to fix the culprit, that is LAD. So we had taken the wire and parked the wire distally, and also here you can see the dog boning of the balloon, that is 2 balloon. And after that, it is unable to, the 1.5 balloon is also unable to cross the mid-LAD tight calcific stenosis. So further, that's why we have done a 1.25 rotabar. And after that, here you can see there is some improvement in the flow. Still the distal LAD is not that much visible. So we just want to dilate the distal LAD with a 1.5 balloon at a lower atmospheres, and also with graded increase in the pressure. And after that, we have taken a cutting balloon, and also we have dilated the medial and the proximal LAD, and there is some improvement in the LAD flow. And we have taken the IVUS. Here you can see there is a dense calcium, thick calcium with a distal cuts in the calcium distally. But however, the calcium in the proximal and mid part of this LAD has not been modified. So that's why either we have to go for a upgrading the rotabar, or we have to go for another plaque modification like the balloon based therapy like the IVF. So that's why we have taken a C2 plus balloon, and we have dilated the proximal to mid LAD lesion. And we have delivered all the 120 pulses from the proximal to the mid LAD. And because of the distal diffuse nature of the disease, we have taken a drug-coated balloon, that is 2 into 30 mm protesi balloon, and we applied the DCB to the distal LAD, and also we have fixed the distal part. Now we want to fix the proximal part with the stent. That's why we have taken a 3 stent and also 3.5 stent proximally, and we have done the pot and also the post dilatation. And this is the flow, and also check shot showing the distal improved flow. And this is the imaging. Here you can see the stent has been well expanded, and also there is no edge resections, and also there is no dissection in the part treated with the DCB also. And here you can see there is a good improvement of the flow. There is some distal tight lesion. We don't want to mess the things. So that's why this is the hybrid approach, where in patients with diffuse disease lesions, going for a proximal stenting and also the applying the DCB to the distal LAD, distal lesions, can reduce the metal burden and also prevents the long metal jacket. And also it can help the if the patient develops instant stenosis or aggressive disease post stenting, there can be an option of the bypass in the future also. And this is the second case, 54-year-old male, unstable angina normal function, baseline investigation normal, and this is the CAG. Here you can see that there is a bifurcation lesion made in a 111 with a tight lesion in the proximal LAD and also tightest lesion in the LCX, that's diagonal. And we wired both the lesions and we have prepared the lesion. Initially, our thought was to go for dedicated bifurcation stenting like a DK crush, but however, this is only ostial lesion, so we just want to prepare the lesion with a cutting balloon. Our default strategy is to go with the cutting balloon before going for DCB, because it will lead to controlled dissections, and also if we go for the side semi-compliant balloon, it will lead to major dissections, and that can lead to decreased flow, and we have to go for the ballot stenting. So that's why I have dilated the lesion, both LAD and the diagonal with a cutting balloon. After that, we have stented the LAD with a Zion Sierra 3 into 24. And also we have done the pot with a 3.5. And after that, we have done a kissing balloon inflation with a 3 into 12 LAD NC balloon in LAD and 2.5 into 20 DCB in the diagonal. And here you can see there is a good flow both in LAD and also the diagonal. So this is the third case. This is a known case of CKD, hypertensive diabetic, and also presented with DHF with heart failure resistant reaction. Is already known case of TBD and also underwent CABG. The graft CAG showed the patent lima and radial artery Y graft to the ramus. And here you can see there is a dominant LCX with tight stenosis near the ostium of the LCX, and also there is a distal tight lesion in the distal LCX. So because of this severe LVA dysfunction, we have kept an IABP and also temporary pacemaker as a backup, because this patient can have an events on table and can go into cardiac arrest. So we have wired the LCX, and we have done the initially with the 2.5 into 15 2 balloon, followed by 2.5 into 15 angioscope balloon. And here you can see after there is some improvement in the flow. And however, with 2.5 balloon also there is some dog bone near the ostium of the LCX. So we have done the imaging. There is a calcific nodule. We have done the IBUS, and also there is a calcium in the proximal part of the LCX, and also then near the ostium of the LCX. So we have taken a 3.5 into 10 mm cutting balloon, that is a Wolverine, and we have dilated the lesion at high pressures. Here you can see that initially dog boning is there with and also however with the subsequent inflations, that the dog boning has been corrected, and also the lesion got healed. And also after that, we have done the stenting from the left main to the LCX with the 3.5 into 44 Zions stent to the mid part of the LCX. And also after we have done with the stem stent balloon, we have done the proximal optimization also. And this is the result after the stenting. Here you can see that the stent got well expanded, and also there is no distal edge dissection. And also we have done the pot with a 4.5 into 8 mm. And also with the same 4.5, we have done the ostium also. Now comes the distal LCX part. So this is a diffusely diseased vessel. So keeping a stent here will lead to future restenosis and also the acute stent thrombosis. So that's why what we want to do is we just want to go for a metal-less strategy. So we have taken a 1.5 balloon, 2 balloon, initially 1.5 balloon, after that 2 balloon, Ryrie balloon, and also you can see there is some improvement in the flow, and also there is some residual stenosis. So we have taken a 2 into 2.25 mm DCB, and we have applied at 8 atmospheres at a solution DCB for 1 minute. And this is the final result. Here you can see. It's a very large LCX. So proximal stenting and also distal DCB, that is going for the hybrid approach can reduce the metal and also the future instant restenosis. So the summary of this my talk is so DCBs can be particularly useful in patients with diffuse disease where CABG and stenting long-term results are suboptimal, and also potential uses in patients with small vessel disease are as a less chances of late lumen loss, and also adequate plaque preparation is mandatory before DCB application. So if the residual stenosis is more than 30%, then you have to further prepare the lesion, and also there should not be a major dissection. If there is no flow limiting dissection, then you can go for the DCB, and the results from the randomized control trials involving large study population are required for the application of DCBs in acute MI, diffuse diseases, and also the bifurcation lesions. So particularly in bifurcation lesions, whenever you are going for a two-stent strategy, particularly in the left main bifurcation where the osteal LCX is an Achilles heel to the intervention cardiologist. So going for the DCB with the ostium LCX with the provisional LM LAD stent will prevent the restenosis, and also the even if you achieve a good adequate MSS in the ostium LCX, going for this hybrid strategy will prevent the restenosis, and also in acute MI where there is a small vessel involvement, going for the DCBs can prevent the metal, and also it will maintain the lumen, and it will maintain the vessel integrity in the future, and also it will prevent the future restenosis. Thank you.
Thank you, Dr. Parthsarthi. So we can see that how we are pushing the boundaries, and we are using drug-coated balloon in different various indications, and with successful result. That is the most important thing. So we have seen all the marvelous cases in the last 1 hour. So we'll confine our discussion regarding the drug-coated balloon, and maybe the certain things we all can discuss. You all can also chip in. Everybody can put themselves on the unmute. I would like to understand one thing from Dr. Nirmal Kumar. Dr. Nirmal has shown some very beautiful cases, challenging cases, and all variety of cases. So what do you do to prepare your lesion when you avoid dissection?
Hello,
Yeah, you're audible.
sir. Question, sir.
So I'm asking, what do you do to prepare your lesions to avoid dissection? Because the main challenge remains, like if you plan a DCB, your ultimate main challenge remains if there is a significant dissection, you end up putting a metal.
Sir,
Okay.
that is the advantage of nowadays the DCB, because you have a very good, strong support of the good drug-eluting stent. But my preparation is that you go with the cutting balloon or scoring balloon, because the cutting balloon and the drug coat this thing, scoring balloon, you can inflate the this lesion with a low pressure inflation, also give the good result, rather than a say non-compliant balloon which produces more dissection, and it produces a micro dissection or micro fissure of the calcium. And second thing, if you do the drug this cutting balloon or scoring balloon, the drug deliverability is good. Lumen gain is more is better than your NC balloon. But if it is a simple lesion, non-calcified, de novo, very simple lesion, you can use the NC balloon also. But complex lesion, to reduce the dissection flow, you use the DCB or scoring balloon. Even if you have a dissection, not a flow limiting, if you have a dissection, you have a doubt, you can do the imaging, or you can take the advantage of the FFR also. If FFR is more than 0.8, means lesion is here hemodynamically is acceptable. You can do the DEB and come out, because until unless you do some dissection, means you are not done the angioplasty. The angioplasty means some dissection will be always there.
So Dr. Arindam, would you like to add something regarding cutting balloon?
No, see, in my cases, in all my cases, in fact, I make it a point to do pre-dilatation with cutting balloon. So that is how I do. And in fact, I also feel, someone mentioned that drug-coated balloon actually is a delivery tool. This is not something by which you are doing any modification of the plug. So this is basically to paint the artery. This is a delivery tool. So it's very important to have your bed prepared. Until you prepare your bed very nicely, the therapy is not going to work. So more than 95% of male patient, I make it a point to use a cutting balloon or a very high pressure pre-dilatation with non-compliant or sometime OPNNC balloons, which I showed in my presentation. And I feel this is almost mandatory.
That's good. We saw that you use that Protesi balloon 3 times, I think, in the same vessel, same balloon. You use a different length, so which is also an advantage of the Protesi balloon. So, Dr. Ankit,
Yes.
how many times, like when you plan, and I think this is a question for all of us, then how many times when you have planned a DCB and you end up putting a stent out of 100 cases, how many percentage?
Uh, in my practice, sir, I usually do the intracoronary imaging so that I can know the lesion morphology, as I showed a similar case for that which has uh, intracoronary imaging of fibrotic, highly fibrotic lumen. So that was the reason we need to use the cutting balloon, and that makes a different type of cuts, and where we can easily deliver the drug which is coated in the balloon. And now the question comes whether we need to have a drug coated balloon made with a semi compliant balloon only, or the NC balloon, where we are using these modality in the calcified as well as the fibrotic lesions. So mostly this is the question. The most of the drug coated balloons are made of semi compliant balloon. If we have already done a cut with a Wolverine or any other cutting balloon, so after using that cutting balloon, and some cardiologists prefer to do the NC balloon also to make the arterial bed. So I usually do only cut the balloon, cut the vessel in intima, so that we can deliver the without using NC balloon at that point. Because if we use NC balloon after the cut, I feel like that delivery can be the challenge. Delivery of the balloon drug will be the challenge.
Okay. And Dr. Nirmal, Dr. Arindam, what is your practice? Like how many times when you have planned and you are DCP, but you end up putting a stent, like because of any reason you found that it is maybe the bend is something like that, bed preparation is not adequate, or dissection is something there, or after doing a balloon, this thing you're finding this haziness, I can't leave behind and coming back. So how many times, how many percentage you like end up putting a stent?
In my practice, almost 80 to 90% cases, I actually I was able to go ahead with my pre-planned strategy of DCB, but around 10 to 20% cases, I had to actually put a stent. So it is not 100% for sure.
Certainly. And is there any case anyone of us has that after putting a DCB, like the patient has to be taken back and maybe in a couple of days or within 7 days and has to be deployed a stent?
Yes, this also has happened. In fact, one of my cases, post CABG LCX ostium, I that though it was a protected left main, I didn't show that case here. Though it was a protected left main, I thought, because lima was flowing, but the OM graft had closed. So I thought this LCA ostium is not a good place to put a stent because chance of ISR. So I went ahead with a DCB. We did very good with bed preparation with cutting balloon. Imaging guided procedure. But in spite of that, within a span of 6 months, patient actually returned with very significant angina, and I saw it again has restenosis, and I had to went ahead with a Lepman to LCX stenting, drug coated metal stent I had to do. So not always your strategy works. In my initial, I am a very big, I'm not a fanatic to use DCB, But as I am getting more and more experience, because now I have experience of using it for more than 2 years now, 2 to 3 years, I have used a very significant number of DCB. I do see, failure of DCB as well. So this is not a solution. This is not a solution which will work in 100% of your patient. But if you meticulously choose, this is a good therapy. This is going to stay. I do have very strong confidence on it, but it is not a 100% solution.
Yeah.
In my opinion, if you have a restenosis with the one type of a DEB, next time you try the different molecule, because initially most of the time we are using the sirolimus coated balloon, and most of the time as a paclitaxel, if you see 1.5 years back, we are using a sirolimus stent, and because we don't have a long size, almost we have only 30 millimeter. Limitation is 30 millimeter. So if there is a very long diffuse disease, you have to use the 2-drug coated balloon. But now with the Protege, they are saying you can do three lesions, cover the 3 lesions also. Still, I'm skeptical about that, but we are using the sirolimus stent, and sirolimus stents, they have a lot of, still the issues are there with the sirolimus. So first time if you use the sirolimus, next time patient come, you use the paclitaxel. Second thing, another thing is the chances of restenosis recoil is very much high with a large vessel. If you are doing more than 3 millimeter vessel, a drug coated balloon, the chances of elastic recoil is more, and you will not get the proper luminal gain, because the larger vessels, proximal larger vessels, they have a more elasticity. The recoil is more with the larger caliber vessels. So you get the inadequate luminal gain. These kind of a patients always is a challenge, and austere L6 is always challenge. Rather than putting a stent again, you do the first time you put the sirolimus, next time you do the try with the paclitaxel, in my opinion. And second thing, NC balloon, regarding NC balloon, you can use NC balloon, opium balloon, all this kind of a balloon in ISR patient, because ISR patient, you need a more aggressive therapy, and you have a stent also, so you don't have a fear of a rupture or perforation or all this, so you can go aggressively, because until unless you prepare the lesion properly, you should not put the depth.
True. So definitely we are pushing the boundaries, and beyond the ISR, beyond bifurcation, beyond the small vessels, the use where I'm finding it, the youngish patient, even in ACS, for all kind of branch lesions and for CTO. Like I have used in last couple of weeks into CTO. The IDD was 33.5 in the beginning, and after CTO it was 2.5, 2.25 something. Gross mismatch, and I knew this is just negative recoil and negative remodeling. And after DEB, after 6 months, this vessel will find it will be 2.753 something. So these are the new challenges. We don't have much data, but definitely we know if and second thing which I'm liking about DEB is keeping the vessel ready, or still having the option of revascularization in the future, particularly young patient with diffuse disease. Like if you do a complete metallic jacket in the vessel, the option of the bypass goes off. But if the DEB is there, the option of bypass always remains there. So I would like to have a quick comment from all of you, and then we can close the session. Dr. Nirmal Kumar, from you first.
Thank you. Very good discussion. We have learned a lot, and knew these things, indication of a DB, and very good cases we have seen. We have learned a lot. Thank you to the Translumina and organizers.
Thank you so much, Dr. Ankit.
On mute, sir.
Dr. Ankit, you are on mute. Okay. No, you are on mute, Dr. Ankit.
Still? Yeah, it's fine.
Yeah.
Thank you so much, all the speakers who have I have learned a lot with all the cases with the and it will going to help me a lot in my practice. Thank you very much.
Dr. Arindam.
Fantastic knowledge sharing. Thank you very much, Translumina, for providing us this platform. And we actually, everybody learned a lot from exchanging our knowledge. Thank you very much.
True. Dr. Archit, if you're there. Dr. Archit, Dr. Parth.
Thank you, Translumina, for giving me this opportunity, and also I learned so much from the seniors, and also the nice demonstration of the guest also. And also I have well-known indications of the DCB. Maybe this DCB will in future revolutionize the interventional cardiology and also the improve the outcomes. And thank you again.
So I think thank you, Translumina, for giving us this opportunity. We all have learned. So learning is knowledge sharing. Knowledge sharing is learning. So this was a wonderful discussion. And despite some delay and all these things, we have all are pretty satisfied with the discussion and all these things. I think everybody who has joined us has gained some insight into the use of DCB. And for me, it was I'm truly, I would definitely acknowledge that this liberal use of cutting balloon, this I find it pretty useful. Like if I'm missing in those 20%, 25% patients where the dissection happens and we end up putting a stent. So this can be a game changing using it more liberally. So thank you all. Thank you very much. And Ehsan, Garima, if you want to add something.
Yeah, so I just would like to have a big round of applause for all of you because, really it has been an enrichment of the thoughts maybe. And basically our attendees have also, got the insights of DCB. So thank you for all the knowledge and basically the engaging discussions between all of us. Thank you so much to all the faculty members who has taken their time out actually, apart from the OPDs and, all of it. Thank you. Thank you to all our faculty members. And have a great evening.
Thank you so
Same
much.
here. Thank you, sir. Good night. Thank you very much.
Good night, everybody. Good night.
Good night.